Welcome back, everyone. And we're going to now hear the last presentation. Mary, of course, as you all know, is a postdoc fellow in our lab from the Aga Khan University. And we're looking forward to hearing your presentation.
Thank you. So I'm also sort of going to introduce myself, but in the context of the work that I have been involved in, I thought it would be a good opportunity to present the work that I did for my PhD. For two reasons: just to introduce the work, and also because I'm at the stage of sort of thinking about what I want to do for my early career fellowship post-PhD. So I'll also welcome suggestions and a lot of questions that will help me frame my thinking. So by background training, I trained as a nurse in Kenya, and then I did my master's in global mental health at King's College in London, and then my PhD at Oxford. Part of which this work was this work that I submitted. And so I'm going to talk to you about sort of two projects that I did that together formed my thesis that aimed at tackling stigma against people with mental, neurological, and substance use disorders in a rural area of Kenya called Kilifi. Now you'll notice that I'll be using the word priority mental disorders, and this was just borrowed from WHO that defined a number of disorders as those that of course contribute to the largest morbidity, for which there is evidence of effective interventions, and for which there's also very high return on investment for these disorders. You'll also notice in my work that I don't only talk about mental health problems, but I also talk about neurological disorders, epilepsy, and dementia. And there's a reason for that. One, it's because, as you will see, part of this work was funded by work that was actually a large grant to tackle epilepsy. So somehow this work fell into that scope. And also because in our settings, we do not have separate care pathways for people with mental health problems and neurological disorders. They're in fact seen together in the same facilities by the same practitioners. So it is actually difficult to separate these two disorders, particularly in primary care, where I'll be presenting this work. Of course, I lifted this figure from the 2021 GBD study, and as you can see, these disorders indeed contribute very high morbidity. And so I know, I will also apologize for just repeating things that may be very obvious or very well known to this lab. But when we talk about stigma, particularly in the context of mental health, or I'll say neuropsychiatry, mental and neurological disorders, this is one of the most influential pieces of work that have guided how we understand stigma in the context of mental health. This is a book by Evan Goffman that was published in 1963, where he defines stigma as an attribute that is deeply discrediting, that reduces the bearer from a whole and visual person to a tainted and discredited one. Now, this definition sort of has two components: the attribute or the mark, and then there's the idea of a stereotype. So where a stereotype is like it's a knowledge structure that is either inherent to a group of people or to a culture, but usually when it's applied to an individual, it has very negative evaluative components. So for example, in mental health, there are stereotypes like dangerousness or incompetence, things like that. But since the development of this framework, there have been very many additions, and a lot of research has gone into trying to define stigma better. And for my work, I used this framework, the Health Stigma and Discrimination Framework, which was developed in 2019, not for mental health, for all health problems, including mental health problems and other physical illnesses like HIV, etc. But I like this framework because it really summarizes the processes and the individuals involved in the experience of stigma. So if I can just point you to the top row, which talks about the health and social impact. So things like morbidity, mortality, quality of life, and social inclusion, which we've mentioned. And then at the bottom, it sort of shows the different levels at which the experience of stigma occurs. And these levels are not isolated, they very much interact, as you will see in my presentations. And then also within this framework, they talk about the drivers, the facilitators, the manifestations, and the outcomes. So it's a really good framework of understanding the experience of stigma in health. And you might, it might be obvious, but then why do we care about stigma in the context of this? And we do know that the proportion of people with the priority disorders who receive minimally adequate and evidence-based care is very small compared to the proportion of people with these disorders, as has already been illustrated by the two presentations that came before me. And so this idea, we call it the treatment gap. I lifted this figure from that study that was looking at the treatment gap of psychosis in rural Ethiopia. And this specific study a treatment gap of about 60%, which means that 60% of people with psychosis are not getting care in rural Ethiopia. But you can think about a disorder like psychosis, which has very overt symptoms, which is very severe and very disabling. And so, and you would think this is obvious that these people need care, but they're not getting care. Now think about disorders like depression, for which the symptoms may not be too obvious, for which there are a lot of cultural nuances in the way they present in different settings. The treatment gap for some of those disorders like depression, particularly in low and middle income settings, can be even 100%, as is the case in Kilifi where I work. And I'll show you results of a situational analysis that I did that was trying to look at, I just went through the retrospective records of psychiatric outpatient facilities to see what proportion of people were seen with a disorder like depression. And as you would expect, over 75% was people with psychosis. The other 20 to 23% were people with epilepsy, and then depression was somewhere between 0.5 to 1%. Yet we say that depression is the commonest mental health problem, which is suggesting that a lot of these people are not making it to care. So, and stigma and this dimension is good because it's not just about accessing care, but are they recovering? Is that care effective? And is there equitable access to care for these people? So this, I really like how this dimension captures the concept of the treatment gap. And I was just trying to visually present just the vicious cycle of stigma and how this occurs. So of course, lack of self-acceptance, not just self-acceptance, even lack of knowledge or awareness. And of course, poor care-seeking behaviors. And even when they seek care, stigma still mediates adherence. So poor adherence to care, and of course, the outcomes that we talked about in the beginning, which is lack of recovery, poor integration into the community, and very poor rehabilitation as well. And this is from the perspective of the patient. Think even about from the perspective of the clinician. As you will see, I will describe a concept of structural stigma and how clinicians themselves participate in this cycle and how they perpetrate stigma and the resulting outcomes to patients. So this cycle just continues and the treatment gap continues to widen for a lot of people. And so how can we reduce the treatment gap, and exactly where does stigma come in? This is one of the pieces of work that really influenced some of the ideas that I developed around this, which was this work, of course, by Vikram and colleagues, which summarized 3 key strategies that we can use to reduce the treatment gap. So the first strategy was around increasing the number of specialists who are providing this care. But as you all know, that is expensive, that is time consuming, it is a long-term investment. But what do we do with people in the meantime? Of course, like Carolina has presented the idea of task sharing, involving non-specialists in offering these forms of care. And something that we're increasingly seeing in the last 3 to 5 years, which is service user involvement. So involving people with lived experience, not just in a tokenistic way, but actively involving them in designing, implementing, and evaluating different interventions. And this work, which was published about 15 years ago now, talked about combating stigma across the life course as some of the other strategies. So even at this point, there was, of course, the recognition that stigma mediates these outcomes. And for us to achieve this, we must tackle stigma across the life course. And indeed, there's been a lot of attention given to stigma in the context of mental health. And in 2022, the Lancet published this commission, which I would encourage everyone to read. It was an umbrella review of about 216 systematic reviews, and a very special. And so, the second author to that author, who I'm sure is known to all of you, Charlene, leads the Global Peer Health Network, which is a network of people with lived experience, and very beautifully included a number of points from people with lived experience in this commission, which to me was one of the most outstanding things that can happen in a scientific publication. But it clearly summarizes the different strategies for reducing stigma, and as you would expect, again, educational campaigns, which we sometimes synonymize with stigma reduction interventions, was the commonest. However, this commission clearly pointed out that one of the most effective strategies to tackling stigma is contact-based approaches. And the idea of contact-based approaches is, as the word suggests, increasing contact between people with lived experience and the population that you're targeting to tackle stigma in. And so we partly informed by this, by the time this came out, I had already sort of started the work, but I'm glad that part of the work incorporated these concepts. I also just went to PubMed and looked at how research has evolved over time. So I just put in the word mental health and stigma in Africa, and you can clearly see that there's been also a very high increase in the scientific output related to the topic of stigma, which suggests that we are beginning to understand the impact of stigma in the outcomes that we are trying to achieve for people with lived experience. And so with that background in mind, the idea behind, so the first objective was I wanted to test the effectiveness of a task sharing intervention in tackling structural stigma, which I'll talk about. And I also wanted to test the effectiveness of a contact-based approach in tackling public stigma. So there are different types of stigma, but these are the two types of stigma that I wanted to tackle. And my theoretical underpinning was that to be able to tackle, to reduce the treatment gap, you must increase both the demand for the services and the supply for the services. And so thinking back to stigma, I looked at what are the types of stigma that mediate an increase in the demand for the mental health services, which is public stigma. That is stigma that is perpetrated by the population to people with lived experience. And then what are some of the barriers that increase supply? And when we talk about supply, we're talking about supply of care, which is structural stigma. And the idea of structural stigma is generally just policies that restrictive policies towards people with mental health problems, and they may be intentional or unintentional. So for example, maybe in the context of low resource settings, an example I can think about is there was a review that was done, I think in 2012, that looked at 45 Commonwealth countries, and it just reviewed the legislation. And it found that about 20% of these countries had their legislation regarding mental health was ratified before 1960. This is before psychotropic medications were discovered. And then they further looked at the legislation that was ratified before the ratification of the Convention for Persons with the Rights to Disabilities, and they found that over 90% of this legislation was ratified before that time. So what does this mean? It means that the legislation does not protect the rights of people with mental health problems, and that's a form of structural stigma. At interpersonal level, when you maybe when we go to like hospital policy level, low prioritization of mental health in the health agenda. So for example, from the situational analysis that I did in Kilifi, I found that less than 1% of the health budget is allocated to mental health. And you can guess where that went, to the psychiatric outpatient facilities, specifically to buy medication. And that's all the investment they do. So no investment in psychosocial services. At the time that I did the situational analysis, there was no psychologist, no psychiatrist, and there were only 2 psychiatric outpatient facilities for a population of about 1.5 million people. So that is an example of structural stigma at policy level. And at interpersonal level, a good example I can think about is an idea that we call diagnostic overshadowing. So for example, a healthcare worker, a person with schizophrenia comes to a healthcare worker and says, I'm having stomach pains today. This person's medical history indicates that this person has been living with schizophrenia for 5 to 10 years. There's a likelihood that, and what happens in Kilifi, for example, is that this person, the moment you come to hospital and your medical records indicate schizophrenia, you are sent to the psychiatric outpatient facility straight away. So you will not even pass through the physical healthcare clinic. And when you get there, the doctor is likely to say, or the psychiatric nurse in charge is likely to say, that is just probably in your head. You're having the hallucinations or delusions again. What if that person has acute appendicitis, which is life-threatening? They are likely to succumb to a physical health problem. So it is not a surprise, therefore, that people with mental health problems die 25 years younger than the general population from preventable causes because of this concept of structural stigma where they're not able to access care. And one of the reasons, again, that is now when a person who has been diagnosed reports to a facility. What about a person who's not been diagnosed? Or what about a person who reports to a primary care clinic, which is not a specialist clinic? Again, there's this idea we refer to as work competency threats, where if a person with a mental health problem presents to a primary healthcare clinic and the clinician is not competent enough to offer this service, the clinician is likely to turn them away because they are not able to help them and they don't want people to think that they are incompetent. So you came to me and I can't help you. The best way to avoid appearing incompetent is to send you away. So as a result, these people do not access care. And so with my first objective, I was attempting to tackle that by building the capacity of primary healthcare workers. And therefore, I thought that's the pathway through which I'll tackle structural stigma. And then for my second objective, I wanted to tackle public stigma. And here I used a contact-based approach, which I'll now talk about. So for this first project, I used a method called participatory video, and Carolina earlier presented photo voice, which is where we use photos. But for my project, I used actually videos. And the contact component, and from the review, from the Lancet review, they actually said that contact-based approaches do not have to be face-to-face. In fact, there is evidence of effectiveness of even virtual contact-based approaches. So in this case, what I did is people with lived experience were trained. Maybe I should probably, before I talk about it, I should probably tell you a little bit about the project. So the project under which this first objective was done was called Difusimo, which is a Kigiriama. Kigiriama is the local language that we speak in the area where I come from. It's a Kigiriama word that means breaking free. So we coined the campaign Breaking Free. And I was funded by the Wellcome Trust for 2 years. At that time, they had a funding pot called a Public Engagement Fund. That is the fund that I was given. And we created this project as a collaboration between 3 institutions, the Kenya Medical Research Institute, where I was working, the Documentary Institute of Eastern Africa, where Simone, the gentleman on the right, is the director. And Simone just uses film. He's a filmmaker, essentially, a filmmaker and a documentarist, and he's a commercial filmmaker and documentarist, but we collaborated in this case for the purpose of Difusimo because the idea was to use art to tackle stigma, and films was one form of art that we were using. And then the other collaborator was the Malindi District Cultural Association, which is an association of traditional healers. And the idea of including them is that traditional healers are in the pathway to care and are a very respected a group of healthcare providers in the setting that I was working in. And so it was a big project, and what I'm presenting is just one element. It included public awareness campaigns, radio campaigns, etc. We do have a website which is currently under development, but I think there's still something left in it. So if you just Google Difusimo, you can learn more about the project. So I have talked a little bit about Kilifi. And I think I have mentioned some of these things, that about 1.5 million people, we have not yet had a population-based survey to quantify the burden of any of the priority disorders. But we do know from other surveys, for example, work that Moses did. Moses was here last year. He has tried to quantify this burden among adolescents with HIV and found a prevalence of about 13%. But we still don't know the precise burden of those other disorders. And as at the time that I was doing my work, there was no psychiatrist, but you will see how part of this work actually informed the Public Service Board on onboarding more psychiatrists. And now I'm happy to say we have 2 psychiatrists in Kilifi. And then we have 156 public primary care facilities at different levels in total. And so I think I will not belabor this point, but in 2017, we just did a situational analysis, and I think I've presented some of the findings of the state of the mental health system in Kilifi. And I'm happy to share these slides. These QR codes will just help you find the links to the full publication. And so I talked about participatory video, which is one of the components that we implemented in the Difusimo study, and the one that actually on which my thesis was based. And so in PV, I'll be using the term PV. We use just films to empower people with lived experience or marginalized groups to tackle challenges that are facing them, in this case, stigma. So what happens in participatory video is that a group of people come together. They are trained basically on just how to use the equipment, and that is it. Now, the editorial process, what to film, this is entirely left to them. They decide how to film, similar to photo voice. They decide what to capture and how to tell their story. And so what we do is basically just train them on the editorial processes and the use of the equipment that we give them. And then you give them the equipment, of course, in a time frame, and you let them film their stories. And this is the picture on the left. There is an example of a session. So they decide where they want to film this, what story they want to tell. And this picture, all the people in this picture are actually people with lived experience, except the two people wearing white t-shirts. These are the people who are just making sure the equipment works, but you leave the entire process to them. So we ended up training 6 people with lived experience in the different priority disorders. And the process of how to use participatory video and the entire training was provided by an institute called InsightShare, which is specialized in using participatory videos for social change. And they trained us on how to use this, and then we went ahead and implemented this. And then, so after they created these participatory videos, we wanted to test the effectiveness in reducing stigma. And so we recruited a total of 420 participants, and these were purposefully selected because we wanted to target people who had the potential to make change. So we selected community leaders, youth leaders, etc. It was a very targeted intervention. And what would essentially happen in these sessions is that the idea of contact is one, of course, the virtual contact, because the people in these films are actually the people with lived experience, but also these people were always present in the room during the filming sessions, and they would moderate the Q&A after the filming. And then we would actually, we would measure the levels of stigma of our participants before the filming, immediately after the filming, and 4 months later. We wanted to do more follow-ups, and then COVID happened, so we could no longer be able to, priorities changed a little bit, but that was the design of this study. And I just, this was shortly before lockdown started. We would screen this both at night and during the day, depending on availability of participants. So that was a night session in a primary school. And then this was a daytime session that we were screening among, this is a group of traditional healers, and we were screening the film to them. You can see me right there. I was really tired and thirsty, but very happy to be there. So this is essentially how it would happen. You would get a community setting, screen this, conduct baseline assessments, screen this, conduct post-viewing assessments, and then follow them up 4 months later. And in terms of, I think there has been a little bit of poor ordering of the slides, but I just wanted to briefly explain the outcome measures that we did. I think it comes later in the presentations. I may have skipped that, but we conceptualized stigma as deficits in knowledge, poor attitude, and discriminatory behavior. And we used 3 different tools. I think I'll just, it should be, yeah, I think it's important that we just go through this. We used 3 different tools to measure this stigma. So we used the, and I think I have a slide of this as well. So sorry about this. We used 3 different tools to measure stigma. So here we go. We used the community attitudes towards the mentally ill scale. This is a 40-item questionnaire that measures stigma, that measures attitude in 4 domains. We have benevolence, authoritarianism, social restrictiveness, and community mental health ideology. So benevolence is the idea that we should just be kind and good to people with mental health problems due to like religious and social reasons. Authoritarianism is the idea that people with mental health are dangerous and they should be excluded from society. And then social restrictiveness, as the word suggests, is that people with mental health should not integrate with other people in the community. And then community mental health initiative is the idea that we should use all the resources within our power to make sure that people with mental health are included. So we sort of have 2 negative constructs and 2 positive ones. However, in the paper that I had just shown previously, we did a validation of this scale. And when we validated it, we found that our work was actually falling under just 3 constructs, not the 4 constructs. So you will see in my results that we actually renamed the constructs based on how our questions were clustering, and we had 3 but not 4 domains. And examples of questions in this, it's a Likert scale. So completely disagree to completely agree, and we have 5 points. And an example of a question in this scale is something like, as soon as a person shows signs of mental disturbances, they should be hospitalized. So you choose what you think in the Likert scale, or something like increased spending in mental health services is a waste of tax money. So you decide, do you strongly agree, do you strongly disagree? And then for behavior, we use the reported and intended behavior scale. Again, it is a 5-point Likert scale, but it has 8 questions. 4 questions on reported behavior, 4 questions on intended behavior. But we only use 4 questions to score the tool, because reported behavior is not really as important as intended behavior post-training. Reported behavior is just what happened in the past. So an example of a question that we use to score is, in the future, I would be willing to work with someone with a mental health problem. And then it's a 5-point Likert scale, and you pick one. And then for knowledge, we use the mental awareness knowledge schedule. Again, 5-point Likert scale with 12 questions. We have and we have 2 main domains. So one domain, we call it just general knowledge about mental health. So for example, people with severe mental health problems can fully recover. We're just testing your general knowledge. Specific questions, we have a domain called knowledge about specific mental illnesses. We test something like, say whether you think this condition is a type of a mental illness by ticking only one box. So there's a list of disorders, 6 of them. There's depression, there's stress, there's bipolar, there's schizophrenia. So you tick one box. Do you think it is? Do you agree or disagree? Something like that. And we, of course, validated all these 3 scales in the Kiswahili language. And like I said, for the attitude scale, we ended up having 3 domains, but for the other 2 scales, the factor structure remained the same as the original 2. So I'm sorry, allow me to go back again. With those 3 scales, we looked at whether there is an improvement post-interventions. And remember, we were measuring this at 2 time points, but the results I'm presenting here is at the final time point, just because we want to know, did the effectiveness remain sustained after 4 months period? So I have skipped the first time point, but there's a paper published on this that for further reading. We found that actually there was a significant improvement in all the domains, and in all the domains there was the p-value was less than 0.01, which suggested that the intervention was actually quantitatively effective in reducing stigma based on the measures that we selected. And you may wonder, well, why did you select these 3 measures? A review of literature showed there are over 400 measures of stigma. There are so many. But we selected measures, we wanted measures that have been widely used in multiple settings and that have been validated in multiple settings, so that we could be able to compare our results to many other different settings. Otherwise, there are multiple stigma measures that you can use. And so the quantitative findings have been published. Again, I'll share these slides and you can just have a look and read more about the processes and the outcomes. So I just wanted to know, well, quantitatively, we've been able to demonstrate that the intervention worked, but did it really? Considering that I say this was a mass campaign, how do we know that it is the PV that worked and not the exposure to the mass campaign? And remember, these people are living in a community. There's a lot of mental health sensitization going on. There's a lot of access to social media, etc. So how do we know that actually our intervention worked? Of course, the ideal scientific way would be to have control group and intervention groups. But one question would, this was during the pandemic happened. So one, it was very difficult to go back and randomize them. Also, we had limitations of time, and maybe that is something that can happen in the future. But one good way to do this was to do a qualitative exploration to see whether really it is the PV that imparted the change that we were seeing. So we went ahead and designed a qualitative study where I included 45 participants who took part in the study, and I included people. So I selected people who both had positive outcomes, like whose stigma levels improved, and those who had negative outcomes, because we had a proportion of people whose stigma scores actually worsened post-intervention. So I purposely selected to include both groups in my qualitative work. And I did not adapt any epistemological stance, because I was just interested in knowing, did the results that you were seeing related to the PV itself or to something else? That was just the question I had at this point. So I did thematic content analysis. Another thing I also examined was actually the language that the participants used, because I thought this was a proxy of the knowledge and the attitudes and the behavior after training. So I'll give you an example. In Kiswahili, when we talk about a person with psychosis, they use the word cheesy. And cheesy is a very derogatory term. But when we were training them in the participatory videos, we were encouraging them to say mtu mwenye wazimu, which would loosely translate to something like a person with psychosis, rather than cheesy in English would be like a psychotic, something like that. So I was looking also for this kind of nuances to see whether the way they were expressing themselves was changing. And this would be a very subconscious way of seeing, because someone can say something, but you can really pick up on some of these nuances in how they describe this problem. So those are some of the things I was looking for. And we did actually, our results were actually very concordant in terms of what we found quantitatively and what we were seeing. We did establish a direct link between the PV exercises and improvements in the stigma scores. And some of the things people are saying is, based on the videos we saw and the opinions I had before, I really gained insights, because firstly, people who are mentally challenged do not want to be discriminated. Secondly, they want to be given the same rights as someone else who is mentally fit. And then another one said, when we finished watching the videos of those people referring to someone with mental illness, I went and found one who had that problem. I approached him and told him I found a solution to their problem. So you can see behavior change, sort of a suggestion of behavior change. And you can also see them talking about things like rights of persons with disability, with mental health problems, etc. So, and you can clearly say, you can clearly see them saying, before I saw the videos, I was like this, and after seeing the video. So that sort of gave us an idea that the videos had impact. And the fact that they were mentioning specific things that were highlighted in the video indeed indicated that the video may have had an impact. And like I said, our results were very concordant in terms of the qualitative and quantitative findings. We compared, for example, some responses from people whose scores were negative post-intervention. And one of them said, after coming to that training and going back home, we had no intention of doing the job. I'm sorry. We were interested in receiving, that is like the training. We were not interested in doing this work because no one told us to do it. We just came for training. We talked for 2 or 3 days and threw it away. So that's when I said, there must be doctors in the field who will be standing upright, steadfastly talking about situation. That is my request. So this kind of post suggested to us that they thought that this is not their job, but they were just glad to come, but they did not really do it. The other thing that we're able to look at is that some of the drivers of change in this intervention was that, one, contact with people with lived experience in mental illness made the experiences real for them. So one person said, the video that I'm talking about was filmed at Red House. After the film, I realized that the girl, the character in the film, was with us in the cinema room. Then she stood up and said, I am the one. And she told us the story of her life. Then I knew it is a true story, not a story that has been edited from somewhere, because I saw her in the video and I also saw her face, and she came back and she was given a chance to speak. That had powerful impact. So they're describing the impact of having both virtual contact and in-person contact. And then another driver was that the videos provided solutions or directions. So one person said, I was able to advise my friend because he has a brother who has those problems. I told him, don't show that you hate them, show them happiness, because you cannot give them everything that they need. But if you show them happiness, that is 100%. And there were many other examples of the videos providing solutions. Others were saying, they told us the health facilities to go to, and I'll speak about the health facilities in the second intervention. So we actually gave them a list of the referral points after watching this film. And then the third driver of change was that the film evoked emotions that made the participants reflect on their own experiences. So one person said, based on the film I saw, I personally put myself in that situation because I was going through it. I felt that a certain burden was relieved from me, and I realized that I was not alone. At first, I thought I was alone and I could not speak about it, just to realize that my colleagues were also going through it. Then I opened and I sought advice. So according to me, it opened up my life. And so one thing that I do not present in this, that is a separate piece of work that we are still, that I'm still analyzing, is the impact of people with lived experience participating in this and some of the unintended consequences. We were intending to tackle stigma, but we actually ended up having people reflect on their own experience and realize that they might actually be dealing with these problems. That was not our initial intention, but this was a secondary sort of effect of this contact-based approach. And so since that time, I'm very happy to say that Difusimo evolved from a community-based project to a non-governmental organization that was officially launched on the World Mental Health Day this year, that I very sadly attended virtually. But the most important thing about this slide is that this NGO was launched as a collaboration between Difusimo, the NGO, and the county government of Kilifi. This was a joint collaboration. And how this center runs practically is that the county government of Kilifi, through the Public Service Board, has assigned at least one member of staff on rotational basis to be based at the facility full time. And all activities related to the county. For example, we have a mental health council that is embedded within the Constitution of Kenya that every county must have. They do their meetings here, and it is referred to as a community resource center. So we have all data about all people in all different stakeholders doing mental health activities within the county. We keep that data and we supply it to the county when they need it. And many other activities take place in the county. And so I think that's a really important thing to mention, that because of the work that we had been doing, this has been taken up by the county, and it is sort of a demonstration at a very small scale of how sustainability can be implemented. And I think I just put this slide here as my personal reflections of how this happened, how we were able to transform a very short and a very small 2-year project actually into a community resource center with grassroots impact. I wrote something there in Kiswahili when I was just writing this slide that says kamkutano ni muhimu kuliko mkutano. And what that means in English is, a direct translation would be the small meetings that happen before the big meeting are the most important ones. And how we did this is that we were constantly engaging the stakeholders outside of the boardroom. So every time there were preliminary results, we would share this as WhatsApp, we would share pictures of events and activities, which is sort of a summary of the 4 points that I was just personally reflecting on and saying, really, you have to build very honest and genuine relationships that are based on open communication. And especially for myself as an early career researcher, we do not have the credentials and the public trust that Vikram and Bethy and the other experienced researchers have. We are just starting. So how do you even change projects or outcomes or findings of research to policy and practice? It's a lot more work because we are only just starting to build our credentials. And I learned something that engage them. It's a journey, it's just not an activity. So continuously engage them and start as early as when you're conceiving the project. And one thing that policymakers taught me in the speech that they made during the launch of this project is that they don't implement a lot of research because they are disengaged from the idea itself. That is just as simple as that. And I also learned a lot from Surab, who was here, our PhD student who left, and he taught me a lot about why policymakers do not prioritize our research findings. Some of them is just that, which brings me to my last point, which is that they do not see the mutual benefit. All they want to do is to get re-elected. So how is this going to help them get re-elected? And one thing I remember when we were trying to, it took about 6 months for us to structure the resource center. One of the things we told them is that this is a deliverable by the president, that every county should have a mental health council and a functional awareness campaign by the end of the year. So if you support this, you've actually ticked that box. So they see where the mutual benefit is for them. So, and I think that brings me to the end of the first project that was tackling public stigma. So now for the second project, like I had roughly outlined what structural stigma is and the pathway through which I saw the work that I'll present tackling that form of stigma. And so now, like I said, this project was, I did this project as part of a funding to my PhD supervisor and a project called Epilepsy Pathways Innovation in Africa. And this QR code is a link to their website. And this project was just about improving the outcomes of people with epilepsy. It was done in 4 sub-Saharan African countries with multiple different studies and outcomes. And one of the studies was the one that I'll present here. But I think an important thing to say here is that sometimes strengthening the mental health care system is not direct and forward. We might not always get grants to our specific mental health questions. You're lucky if you're funded to do work on depression or psychosis or anxiety. Sometimes it comes through different pathways. Like I was able to implement this project through a project that through funding in epilepsy. That is sometimes how this works. And I've found myself continuously working at the intersection of mental health problems and neurological disorders because sometimes funding doesn't come directly. And I was implementing the mhGAP. So I'll just kindly request by a show of hands who is not fully familiar with the mhGAP. Okay, so I will, we had a video here that we prepared as part of this project, the EPINA project, that was describing what the mhGAP is. So I'll just play it for the sake of, to make sure we are all on the same page. The sound? My volume. Oh yeah, I have used it now.
And it was developed by the World Health Organization in 2000 GAP Action Program. The mhGAP stands for the Mental Health Gap Action Program, and it was developed by the World Health Organization in 2008 and subsequently revised in 2016. Its aim is to build capacity among primary healthcare workers who are not specialized to enable them to diagnose and manage priority mental, neurological, and substance use disorders, specifically epilepsy, depression, psychosis, dementia, substance use disorders, child and adolescent mental and behavioral problems, suicide or suicidal behavior, and other significant mental health complaints. Here in Kilifi, the study is targeting 128 primary care facilities, and our training design includes training a cluster of 8 facilities, and therefore our estimated training time will be a total of 16 months. After every training, we follow up our trainees quarterly with supervisory meetings, which are offered by specialists. In this case, in the case of Kilifi County, these are 2 psychiatric nurses, 1 clinical officer trained in psychiatry, and 1 clinical officer trained in the management of substance use disorders. The study was informed by the results of a situational analysis that we did in 2017 that showed, among other things, that the human resource for mental health in this county is limited, despite other studies showing that the burden of these disorders is very high in this setting. The primary outcome of our study is actually changes in proportions or the rates of cases detected at the primary care level. And the secondary outcomes of our study include things like the quality of life of the patients will be managed by the trainees, their levels of disabilities, as well as the stigma levels of the trainees after the intervention. We hope that in the end that this Kilifi becomes the blueprint or the template for scaling up of such activities in the entire country. And we also hope that our stakeholders and the policymakers can take this up and scale it to the other facilities that we are not able to reach primarily due to constraints in resources, because this training is very resource intensive. Thank you.
And I think so that that presentation has actually summarized the entire study that we were implementing, the mhGAP, and it has also talked about the situational analysis, the primary results, but I'll present a bit of that as well. Before implementing the guidelines, I just wanted to mention that we had to contextualize the guidelines and we had to make some changes. And at the time of contextualizing these guidelines, we were in version 2. And as we know, in 2023, there's an update again, there's an addition of the anxiety module, which at this time had not been added. And just to say some of the changes that we made, like I said, this was a primarily epilepsy study. So we made a lot of changes to the epilepsy module compared to the others, which is important for me to mention because you will see some differences in the results or in the primary findings. One of the things we did to contextualize the guidelines was we added a non-convulsive module in the epilepsy training. In the mhGAP, non-convulsive epilepsies are not really mentioned, but we added that. And there are many other contextual changes that we made that we have outlined in this paper. I think I have summarized this in the video, but the design of implementing these guidelines was a step cluster randomized design, which just means that at baseline, everybody is a control. And then over time, clusters of 8 facilities each move to the intervention group so that at the end, everyone has control data and everyone has intervention data. We ended up training 172 healthcare workers from 128 primary care facilities. We had 156 facilities, but the 26 did not qualify. They were either closed or they were under renovation and they could not participate in the entire duration of the study. So we ended up with 128. And I think I've mentioned the primary outcomes. We were looking at the changes in the proportions of cases detected at primary level. And the denominator that we are using is just retrospective hospital records from all the previous years. And this might look very simplistic, like, so what was the intervention? How was it being done? How was the monitoring and evaluation? We simply just wanted to check. If we train the primary healthcare workers and leave them in a pragmatic setting, will they detect and manage where possible or refer where they need to? That is simply what we wanted to do, because like as Vikram said, it's better to do something than nothing at all. So we were really just keen on seeing, can they detect and where relevant refer or where possible manage using the guidelines. And we trained them both with the hard copy of the guidelines and the soft copy, the app version of it in the supervisory sections. And then the secondary outcomes, we looked at the stigma outcomes of the healthcare workers and the severity of illness, quality of life, and disability of the patients. So for the severity of illness, we used the clinical global impression scale. And then for the quality of life, we used the WHO's brief version, the 26-item QOL questionnaire. And then for disability, we used WODAS 12. I think I had gone through this were in the wrong place, but I've already sort of outlined what the measures were, and this was the that was validating those measures. So in terms of the primary outcomes, were the healthcare workers able to detect these disorders and manage or refer them appropriately? You can see, perhaps probably guided by the p-value, that the largest effect size was in epilepsy. I may ask again for you to guess why, but one of the reasons was, like I said, there was very intensive training and supervision in the epilepsy module. Secondly, for the past 25 odd years in this setting, there's been extensive research on epilepsy. In fact, the group that I was working with is a group that specializes in epilepsy. So these clinicians have been exposed to epilepsy as a concept and as a subject area for a long time compared to the other disorders. You will also see that there was an increase in the number of people detected with depression, but the increase in psychosis, although there is a positive coefficient, it was not significant. The reason that we suspected for this was that, remember at triage stage, at the primary care stage at triage, when a person comes in with psychosis, the chance that they'll be allowed to see a primary care physician is very little. They will usually directly be referred to psychiatric facilities. So it is likely that the clinicians did not even get a chance to review these patients. We had a number, but this is probably because maybe the clinician was the one doing the triage and not someone else. Because what we did after training is that the facilities knew there's someone trained, so they would actually refer to this person. But with psychosis, they seemed to have referred them directly to the tertiary facilities. We had improvements in dementia, in substance use, again, no improvements in suicide, and then also no significant improvements in other significant mental health complaints. For us, for the other significant mental health complaints, to us, this sort of was a positive, even though it was not significant, simply because once they were trained, they were now able to identify the disorders better, and they were less likely to diagnose someone as mental health complaints. They were diagnosing them with more specific disorders, although we know now that we are moving away from strict diagnostic categories, which is a separate question. Now, when it comes to attitude, the bottom graphs are showing the 3 different domains of attitude that we ended up coming up with after we validated the tools. We saw that it improved their knowledge, their general knowledge, but not knowledge about specific mental illnesses. And it also improved their intended behavior. The reason for this is because, remember, we were just asking, these are clinicians, these are people who've gone through medical school, and the questions were simply asking, is schizophrenia a mental illness or not? Of course, they knew about this at baseline even before training. So this question, there would definitely be no improvement. But when you look at the attitudes, the different attitudes, the variable that you want to look at is time, the one at the top, the purple one. There were significant improvements in all 3 types of attitudes, which suggests that this training actually improve their attitudes towards people with mental health problems. We wanted to explore this knowledge thing further, and the mhGAP provides multiple choice questions that actually examine them on very specific clinical details, like the dosages of drugs, the types of symptoms, etc. When we looked at it this way, we actually saw significant improvements in all the disorders that we trained them in. So the baseline was the green, and then the post-intervention was the red one, and there were improvements in all the modules, which suggests that they learned something after the training. They learned something of clinical significance or importance after the training. And then when we go to the patient outcomes, we selected 250 patients. Initially, the idea was to select 250 patients randomly from the trained facilities to measure these outcomes at baseline and then as they went through treatment. And we evaluated these outcomes every 2 weeks for a period of 6 months. Which was actually very resource intense, but it was really helpful in monitoring the progress over time. There were significant improvements in all the domains in terms of severity of illness, all the subdomains of the quality of life, and in terms of disability. And these were patients who were directly managed by the trainees. And again, so the actual paper is still under review, but we have availed the preprint, and you can just have a read at the outcomes and the measures, etc. And I think I would just like to finish with this slide just to say that this work was, there were 2 massive teams running these 2 different projects. My project manager there, Judy, at the bottom here, which looks a little bit cut. Oh yeah, here we go. These are the team of youth that were running these events day and night in different settings, because remember the pandemic was happening. We couldn't gather large groups, so we had to send people simultaneously in different places. And then that photo is the master trainers, the trainers who ended up implementing the trainings across the 128 facilities, the EPINA team that was working in the larger projects, and then of course my supervisors who supported me to finish the thesis. Thank you.
Thank you, Mary. That was a real tour de force. Questions? Laura, and then Anushka?
Yeah.
Laura first.
Mary, this was amazing. Thank you for showing us some of your work before you came here. It's really helpful to understand more of your background. My question is maybe a bit of a tangent, but I've been curious when I've seen epilepsy categorized as like a mental health condition. And I've seen that in a number of places, and I think it usually is in sub-Saharan Africa from the places I'm familiar with and have worked. But I'm curious what your thoughts are on that. And this might just be my lack of training in more of a medical background, but I would think you'd intervene on that in a very different way. And I categorize it myself as more of a physical health condition, but I'm just curious what you think and what your experience has been working with that group.
So that's a really good question. And we had that same curiosity when we were looking at trying to look at how the population understands these different disorders. And we did some qualitative work to try and understand how do they understand and categorize these different disorders. Epilepsy, you're very right, is incidentally understood as a mental health problem rather than a neurological disorder. And it is for cultural reasons. It is the way that epilepsy manifests itself and the beliefs that people have about the causes of epilepsy itself. So of course they believe that it's caused by evil spirits, and they believe that because of the seizures and the shaking, the person is possessed, etc. But through the work that has been happening in this setting, which I cannot take credit for over the past 20 years, one of the things that has helped people understand that epilepsy is a neurological disorder is, for example, having empirical measures that are not clusters of symptoms. With epilepsy, you can take an EEG and show someone that these are the brain waves, and you can actually explain and have a physical finding, which unfortunately is not the case for mental health problems. We do not have biological measures. So people understand it because of the way it manifests itself, but in this setting, because of the lot of anti-stigma campaigns and awareness related to epilepsy, people are now understanding it more than neurological disorder. The reason why we are categorizing it and we can't treat it differently is because the same healthcare workers see both groups of patients. Kilifi has no neurologist. The only one they've ever had is Professor Charles Newton, who is a member of a research team, not really a clinician. So they end up being seen in these facilities, and therefore we find that it's important to build capacity for both. Another thing is the very high comorbidity between epilepsy and mental health problems like psychosis and depression, etc. So another thing we try to do with task sharing is integrated care, so that they're able to receive care for the full set of conditions.
I'll say that often in public sector settings, if they're government psychologists, they will see all epilepsy with the psychiatric nurses, and epilepsy is the thing that gets treated. So often for us, what the psychologists ask for is, can we learn how to do psychotherapy? Because we don't want to treat epilepsy. But epilepsy is highly treatable.
Anushka?
Hi, Mary. Thank you so much. I really enjoyed your presentation, and stigma is a big interest of mine as well. So it was really, really wonderful to hear you thinking, the theoretical frameworks, and the really good work you've been doing. I have two questions for you, and they're both about the first project. So my first question is, I want to know a little bit more about the actual intervention. So you mentioned that it was PV plus face-to-face. So I want to know a little bit more about what happened. So we're all in this gathering space, we're in one of those community circles. How long are people sitting there? What's the order? What are the people saying face-to-face? Is it relatively systematic and structured, or is it, more kind of spontaneous? Are all 6 people who had the lived experience creating the videos there? So a little bit more about the face-to-face portion of the intervention. And then my second question is, who were the people with lived experience? I wasn't clear from your presentation if it was just psychosis, so if it was multiple disease conditions. And I was out using the restroom for the first couple of minutes, so if you talked about this, that's just my ignorance. But if there were different conditions represented, I'm really curious if you saw qualitative distinctions in how stigma showed up, and then was also the trajectory of reducing stigma, essentially, because it looks different for sexual violence than it would for schizophrenia. I'm really curious to hear your thoughts on that. Thanks.
So the intervention itself was, so I'll start with the last question, which is like the different categories of people. So these were, first, just to mention that we did not implement the child and adolescent module. This is currently actually being implemented as we speak as a separate module. So we did everything else. And these 6 people were people, 1 each with the different disorders, 1 each with the different priority disorders. And in practice, so they had created their participatory videos, and we matched them into like one film, which showed the 6 different sessions, and each was just about 5 minutes in total. So it was like 30 minutes of viewing. And then after that, what would happen is they would stand up and say, I am the one, you have seen me in the film, and I'm happy to moderate any questions that you may have. That was simply it. So the face-to-face component was that they were all present in the room at any one time filming, and they moderated the question and answer sessions, and they introduced themselves and briefly retold their story verbally after the people watched the video. So they would answer questions about what they had spoken about and what people had seen in the film. That was it, basically.
That's amazing. Thank you. That's really helpful. And then the 6 conditions, is it these 6 conditions?
Yes.
The ones that you're showing up over here. That's great. Really interesting. Well, thank you.
Oh, and I didn't have the question you asked about qualitative differences. I didn't really look at that, but that is something that I should probably consider in future work. Thank you.
I mean, it's a good point. It was a question that I also had, because stigma is experienced quite differently. Mental illness, we treat it as one bucket, but actually certain conditions are viewed in very different ways by the same community. Certainly I'd say, at least in the US today, depression is far less stigmatized than psychosis is. And psychosis is far less stigmatized than substance use conditions are. So there is a kind of a hierarchy of stigma. And I kind of think I kind of remember back how certain conditions have actually, the stigma has reduced due to a variety of different reasons. One good example being autism. which today is like, it's very, very common for people to come up and say, my child has autism, it's like there's virtually no, it's like my child has, some other kind of chronic condition. So it's an interesting issue. Stigma is not static. It changes because of many things. Your intervention is very impressive, and I'm not at all surprised that you went to the Lancet, because it's extremely uncommon for stigma interventions to go beyond knowledge attitudes. And we all know that alone is a huge reporting bias. If you go through a training on stigma, almost inevitably when you're asked a questionnaire again, you're going to answer it differently. But what really matters is behavior. And behavior in the form that you've shown, that is to say case detection, and then even more powerfully, clinical outcomes. That means your practice has changed. Those are really rare in the literature, very rare. You must be one of the only, I think Brandon Court did one, the Reshape trial in Nepal, but there are very few trials that have looked at behavioral outcomes. And I think your attention to that outcome is going to make this work extremely impactful.
Mary, thank you. And so in a similar vein to what Vikram was just saying, have you thought about what you want to do next with this? Because just starting off with the initial questionnaire about how do you assess stigma, it would be interesting to see how that compares to other areas. How much of the stigma is personal, how much of it is cultural, and if cultural, how much does it vary county to county, nation to nation, continent to continent? But have you given any thoughts on what you want to do next with all of this?
I still am thinking actually, and I think Vikram and other mentors are just discussing exactly how we can push this work forward. But one of the ideas I'm actually thinking about is what you've highlighted, which is the cultural nuances that come with the understanding of stigma. And I hope that's one area that I'm hoping to explore moving forward definitely. So still thinking, but thinking.
Mary, thank you so much. In line with what you just said, it made me think about, you mentioned the life course perspective. So assessing a stigma from the developmental perspective, because the stigma is different from youth than from older adults or adults. So that would be a great part of that next step.
Thank you for the suggestion.
Question. Thanks a lot. This was very, very interesting work. While you were doing the recordings of the individuals, when you just started off, was there any hesitation at all? And how did you come up? There was in people sharing on the videos, or even standing up later in a gathering to say, this was me. If you have any other questions, I'm here to answer them.
So first of all, how we identified the people with lived experience was we identified them through the psychiatric outpatient clinics as champions, people who are already doing this but did not have a formal platform to do it. So they were actually more than enthusiastic and excited to share their story. They just never had a chance. And in fact, one of the findings that I'm getting from assessing their impact on them is that they wish they had more opportunities to do this. And one complaint they had is the project ended too soon. They wanted to do this more. And through the resource center, now they have a platform to do that. So actually one of the things we do is at least once a week, one of them is at the resource center to share experiences with visitors and people who come in to ask questions. So if anything, one thing we learned is that a lot of people would like to share their experiences but lack the platform.
Julia?
Yeah, thanks, Mary, and congrats. That's very impressive work that you do and really very well delivered. I just have actually, it's more of a comment and an idea for you in the future, because this whole idea that of filming and video and changing behavior reminded me to this, like this very, very, very highly cited and very important econ paper in the American Journal of Economics, where they basically tried to test the power of telenovelas, of soap opera in changing humanity. And this thing that you said about like, how do you actually measure whether the video actually had an effect? because obviously there could be so many other things. The one thing that I did, which is I guess like a very large scale that you could do at some point, is, I mean, they had some geographic differences in like some areas of this was all in Brazil. Some areas of Brazil did get access to the telenovela before others, so they had a bit of heterogeneity there. But actually, how they tested the impact of the of like soap operas on this was because people started naming their kids and after the characters of the telenovelas. So maybe for your future project, you can start creating these personas and then see whether there's any change there. I think it's a very powerful technique that you have, and I think it'll be very cool to see it at a larger scale.
Thank you.
Thank you.
Okay, well, thank you so much, Mary, for this excellent presentation, and always thank you, Katie, for organizing a super program.